before you plan what should be the next plan of action in this patient. So what are the indications of offering only cataract in these eyes? One, if it's just a PACS, sure, you can do that. If it's PAC, which means the pressures are high, but you don't have optic neuropathy, you can do a YAG laser peripheral iridotomy, and then if the cataract is significant, just take it out. You might get an extra lowering of intraocular pressure as well. You have medically controlled primary angle closure glaucoma, and the cataract is showing up. Remove it. Clearly remove it, and you're going to probably be able to even reduce your medical therapy thereafter. Appositional closure is persisting despite a patent PI. Some of these patients also benefit with cataract surgery. When you have your PAS less than, PAS means peripheral anterior synechial, synechial closure of your angle less than 2 quadrants, again good candidates will do well just with cataract surgery rather than a combined. And of course, you've got to have a significant cataract in these eyes. Just to show another category of patient over here where laser PI is done in both eyes, left eye is doing fairly well with hardly any damage, right eye has significant superior arcuate, and the patient is on 2 AGMs already, and now the pressure is again becoming a little uncontrolled and going above target. So either we can add a third drug, but the patient also has some cataract, or we can suggest a cataract surgery and see if the IOP lowering gives us stability and a pressure where we might not need the third drug, and also rehabilitate the patient. So these kind of scenarios can really, really fit into situations where cataract surgery can help. But remember, cataract surgery in angle closure eyes is a little trickier. It's not the same as eyes with deep chambers. You can have a higher risk of corneal damage. Your lens iris trauma is not uncommon, and also sometimes the posterior capsule can be lax and it can trample in, making the risk of PCR higher than usual. And of course, aqueous misdirection is something that you can see in such eyes, so you always have to keep it in mind to be vigilant, to pick it up if at all it is showing in the post-operative period. You compare phaco with trab and angle closure eyes, we have seen that the complications of only trabeculectomy in angle closure eyes is significantly higher than open angle eyes. And also when you compare cataract surgery with trab, you get a very comparable intraocular pressure reduction in many cases. As you can see in this study, 34% of IOP lowering was seen in only phaco arm compared to trabeculectomy where it was 36%. So pretty comparable, and trabeculectomy had significantly more complications. So only cataract surgery does have a huge role to play when you're choosing between what to do. Pseudoexfoliation, again, sometimes we want to offer cataract surgery earlier, but of course if the disease is advanced, combined surgery will have to be offered. IOL considerations before I move towards the combined. Multifocal lenses are not an absolute contraindication, but you need to know that the contrast is going to be an issue in these eyes, and especially if they have advanced glaucoma, your multifocality might not be optimally of use. Toric lenses can work well, but the access or the outcomes might not be absolutely comparable to only cataract, especially if you're combining them with trabeculectomy. So just to now go ahead and say, when do you do a combined surgery? We asked the same questions in the beginning of the presentations, and if I go back to those questions, cases which are uncontrolled on maximum medical therapy, where you have a compliance tolerance issue, patient is developing allergy to most of the drugs, or the patient cannot put the drugs, cannot afford the drugs, or you're not able to achieve the target IOP despite best measures with the medical therapy. Or you can see that the ocular surface is taking a beating and the patient's eyes are suffering with the ocular surface disorder caused by the drugs. And the cataract is also warranting visual rehabilitation. So, or the patient does not have access to healthcare, he's coming from a place where he might not be able to buy the medicine. These are all situations where a combined surgery can be very, very helpful. As you can see here, this patient, let's say, has a cataract and a lot of ocular surface disorder, then yes, this patient is a candidate for combined surgery. Or a patient who has moderate to severe field effect loss, IOP spikes can be a challenge in the early postoperative period, we might want to do a combine. I already mentioned low socioeconomic status patients or cost is a concern, yes, do a combine. And in patients where the pressures are uncontrolled and our target is to bring them down to 10s and 9s and all, and the cataract is not significant, that is when trabeculectomy alone has to be offered, because IOP control with trabeculectomy alone is far superior than the combined surgery. So that balance has to be maintained. So in angle closure eyes, we already discussed when to offer cataract surgery alone. But if you have 3 or more quadrants of synechial closure, or the angle closure disease is uncontrolled with medications, or the disease is very advanced, then combined surgery again is highly recommended in this situation. So this year, I think we've already mentioned that only trabeculectomy is associated with higher post-op complications in angle closure eyes. And cataract surgery alone is effective enough, but not as effective as you want in a particular case because it's very advanced, and combined is your option. Antimetabolites are routinely used in your combined surgeries. They have other alternatives like Ologen and all, but for all practical purposes, we are all using mitomycin C in our combined cases of trabeculectomy with phacoemulsification, and we've all moved to two-site procedure over a period of time from single site because it does seem to show better outcomes. And conjunctival flap also, now we all know we want posterior application of mitomycin C, so we are all making fornix-based conjunctival flaps, and these are recommendations made by the consensus series of World Glaucoma as well. I will not show you the surgery because Dr. Shweta has already shown you the surgical steps. I will just show you a good trabeculectomy should look like this. The bleb should be diffuse and large and not thin-walled and not vascularized, and not every patient is going to give you this outcome, and the risks of failures and all are, of course, various, and it's beyond the talk today. And we also said that indications of trabeculectomy I mentioned when you really, really want very low IOP and you're dealing with advanced glaucoma or risk of snuff outs, you do not want to combine. Only the situation where you can't do two surgeries, the patient is vulnerable, yes, combined might be a possibility. Trabeculectomy remains the gold standard, but of course there's MIGS now, and in rare situations, in very advanced, complicated situations, the tubes are also there, which I will not be discussing in this presentation. Here again, when we mention three options, only cataract, combined, and trab, what is it that we know? Only cataract, visual recovery will be good. You can help the anterior chamber depth and angle and have some IOP lowering in the angle closure eyes, which is of significance in that subset of glaucoma. In open angle also, you might get some lowering, but that is not a therapeutic effect that you're looking for, and risk of IOP increase in the post-operative period is there, small, but there. Combined will give you both IOP lowering and visual rehabilitation, and the risk-benefit ratio will have to be measured before you advise it. It's technically more demanding, and the bleb failures can happen over a period of time. In trabeculectomy, you will get the best IOP lowering, but you have to understand that cataract surgery later can still increase the possibility of bleb failure. So the sequential cataract surgery can compromise the bleb over a period of time. So you don't have a perfect answer. You don't have one style that fits all, but knowing what are the things available and what can be in best interest of the patient might be the way forward in your practice. Last slide over here, then phaco with MIGS is something that is now picking up steam in India, and these iStent has come to India. You have the KDB available. People have been using ECP, and many of us are also doing the bang to try and do the ab interno trabeculotomies. So basically, all these procedures do give us IOP lowering ranging between 2 to 8 millimeters of mercury. They can only be done in eyes with open angle glaucoma, and mostly they're combined with cataract surgeries, and they're used as an alternative to offer them a reduction of intraocular pressure and reducing the dependency on the medical treatment, and hence improving the quality of life. So I'm going to stop my talk here, but please remember MIGS, the cost is a large concern, and it's a very vast topic. I'm sure you've heard Dr. Vanita, and there'll be more introduction on MIGS, but it is something in a kitty that's going to now play a role in the mild to moderate segment of primary open glaucoma eyes, where cataract surgery is advised or is required, and MIGS might come handy to add an additional IOP lowering. Thank you. If we have any questions, I can take that.
Thank you, Dr. Reena. That was quite a good overview, great overview of the combined procedures, covering almost all points. Thanks very much. Please remember, cataract surgery or clear lens extraction, one indication which has come through this talk is that you can do it in angle closure glaucoma as a primary treatment. So do we have Dr. Vinay Gupta? Yeah, I didn't see you. Okay. Can you introduce yourself, please?
Okay.
Yeah.
So
because
I am Dr. Vinay. I'm a professor at RP Center in AIIMS, Delhi, and I shall be talking to you about secondary glaucomas, which is a huge topic in the whole textbooks of glaucoma. Nevertheless, you have to know everything about secondary glaucomas. So the whole idea of me taking this talk is
First I thought I
that
will
it
time
is
because mine is-
interactive,
I don't
so
know.
I will ask some of you to answer some of the questions because it's going to be case-based and you're going to try and tell me what is the diagnosis, what is the treatment, and all of that stuff. So here is a 35-year-old woman who comes to us with decreased vision. I think this ये पूरा नहीं आ रहा है उसमें screen में. She comes to you with decreased vision and she has low-grade pain, redness for the last 13 years, and she's been putting steroids drops on and off. She's been operated for right eye vitreoretinal surgery with SF6, and she has also had after that a cataract surgery in her right eye, and now her IOPs in both the eyes are 43 and very high. So this is how her anterior segment looks like, and you see something which is unusual. The right eye has had a cataract surgery, and now look at the right eye which has a higher pressures. What do you see? Anyone can raise their hands and tell me? Okay, scleral thinning. You can see some amount of bluish sclera in that particular eye which has undergone a cataract surgery. So can you now start thinking of some diagnosis why she developed the glaucoma in the first place? Anyone? Okay, it could be steroid induced. Anything else? What is the basic pathology for which she may have been using steroids? So if there is a scleritis, there is bound, and go back and see her corneas. See the corneas. Can you see some amount of corneal opacities here? By the time she has come to you, she has had multiple episodes of scleritis, uveitis, maybe some amount of keratitis. Okay? And now the pressures in the right eye are high. She has got a advanced cupping in the right eye. So the diagnosis is? Pardon? Steroid induced. But what do the angles show? What do you see in the gonioscopy? Closed angles. Yeah? So there is some amount of uveitis, some element of uveitis. Yes? So probably there was a uveitis with scleritis. Yes? Any patient who has uveitis and scleritis has got some autoimmune problem going on. Yes? So it was a keratouveitis with scleritis, and she developed a secondary glaucoma. Okay, she's had a vitreoretinal surgery also in the right eye. Okay, and she's had, of course, the left eye is a relatively high pressures because of the steroids that she has been using. But the right eye now management, can anyone tell me? You have to manage that advanced cupping, the high pressures. Bolo? Very good, excellent. क्यों नहीं कर सकते? Okay, thinning है. Another reason is this is a vitrectomized eye. Okay, so therefore the failure of trab is very high. So basically you must understand in glaucoma, as we stand today, we are basically such cases, we have got three options: trab, tubes, and cyclophotocoagulation. So now in an exam you have to only answer any of these three. Just mumble jumble, say something. Okay, whether it's a trab or a tube or a cyclophotocoagulation. So basically in this particular case, it is, as you rightly said, very rightly said, trab will not work. Okay, but the main reason is it's a vitrectomized eye, and that's why the trab will not work. Okay, very good. Now we come to something which is more complicated. This young man who comes to us with high pressures on maximum tolerable medical therapy. Okay, he's got shallow anterior chambers and he had undergone an ICL 2 years ago. So he had a ICL done, and before the ICL, the right eye, which is shallower, had a minus 13 diopters. Now his vision is 6/18. Okay, the ICLs are there in place. And look at his disc. Advanced cupping in the eye. Okay, so we all know that there is a possibility that the ICLs can cause an angle closure. And look at the vault of the lens. This is the vault of the ICL. It was almost like 800 microns. So it's pushing the ICL pushing the iris anteriorly. and causing an angle closure. So it is definitely a, what kind of glaucoma is it? Pupillary block. Anyone else? How does a pupillary block configuration of the iris look like? Yes, it looks like this. So what kind of configuration does he have? It's like a volcano. It's going up. So what is the glaucoma he's having? Okay, he's having a kind of phacomorphic glaucoma that has been induced by the ICL, right? The iridotomy is not going to work in this particular case because the ICL itself is causing the crowding of the angle. If it's a phacomorphic glaucoma, what do you do? How do you manage it? You remove the lens. Yes? So in this particular case, what can you do? Remove the ICL, one option. But what is going to happen? His anisoconia, he's minus 13 diopters in that eye. Okay? So again, I told you there's only 3 options in glaucoma: trab, tube, and cyclophotocoagulation. So a trab was done in this particular case. Okay, it's uncommon, but yes, the trab was done and the trab worked. We didn't have to explant the ICL, and his IOP comes down, right? And all you need to do is to manage him further, just to follow him up over a period of time. In this particular case, a lot of people would have removed the ICL. But ICL removal is not the option because it's going to have problems for his vision. So now he is 618 still with a trab, yes. Yeah, we can do that also. We can also do that. That could be a second procedure just in case the trab doesn't work. But if you remove the ICL, you do a phacoemulsification in a high myope, you can still land up with some vitreoretinal complications. Trab just does not really, you can do high myopes, and trab does not really cause so many problems. So it doesn't cause, you could say that we could put an eye stent. Some people do eye stent or something like that. Obviously that is another option, but with an angle which is slightly crowded, eye stents would not work so well. So the trab did work, and fortunately. So this is just to tell you that this is another kind of glaucomas that you can encounter, okay? There could be ICLs with open angle glaucoma, there could be ICLs with closed angle glaucoma. So that also needs to be managed. Now another case is this young teacher comes with high pressures in one eye, and he's on maximum tolerable medical therapy with a relatively thick cornea in his right eye. And this is the anterior segment picture. Okay, so all of you are very clear. This is a iridocorneal endothelial syndrome, right? It has 3 types. Anyone can tell me? The Chandler's, then the Cogan-Rees, and the essential and the iris atrophy. The progressive iris atrophy is what he has got here. Okay, and this is the specular picture. But what is characteristic are the ice cells. So I hope you've all seen how eye cells look like. Okay, it's these speckled like stars in the sky. You can see hyperreflective areas in the center of the hexagonal cells on confocal microscopy. This is almost sine qua non of ICE, iridocorneal endothelial syndrome. So generally it is a unilateral disease. But what could be the differential diagnosis? If we had not done a specular, if you had seen this kind of picture, what else could have come to your mind? Pardon? Axenfeld rigors? Yes. Anything else? What can cause so much of iris atrophy? Generally not, but angle closure rarely. Okay, but this is a diagnosis you cannot miss. Axenfeld rigors is generally bilateral. Okay, but if you see a unilateral picture, this is ice. And generally, ice, if it affects one eye, there is some amount of poor endothelial even in the other eye. So can anyone tell me what is the pathogen? This is the optic disc of this patient. Can anyone tell me what is the presumed pathogenesis of ice? What is the etiology? They're not born with it. Pardon? बोलो बोलो. Autoimmune तो नहीं होता है. Autoimmune किसी ने बोला नहीं है. It's epithelialization, probably a viral etiology is what is considered. So the question is, what is the management? They are very difficult to manage, these cases, primarily because you have to deal with the endothelium, which is bad, and the glaucoma, which is worsening the endothelium. And in this case, it was just not a glaucoma actually, it was an ocular hypertension, which would have turned into a glaucomatous optic neuropathy in due course if the pressures were left uncontrolled. So I'm going to tell you the management of this patient. It was not very good. A trab was done, then the releasable sutures were removed, massages were done, needlings were done, the IOP just didn't come down. Okay? So the question in these cases is, if the trab does not work, then of course you have to put a tube, which is again not a very good procedure because anything that is going to decompensate the endothelium. So generally the course is very prolonged and not very good, and that prognosis has to be told to the patient up front. This patient is another young boy who has come with a vision of 6/60 and had his history of trauma with a cricket ball 2 years ago in that eye. So generally secondary glaucomas are unilateral. So when you see glaucoma in one eye, you're always looking for a secondary cause generally, yeah? But the other thing is, so what do you see here? What is so striking? So you see traumatic mydriasis. Anything else? What are these black spots you see here? Pardon? Clots, blood clots, okay? So which traumatic glaucomas are going into, which trauma patients? A patient comes to you with trauma in the emergency. Which patients are likely to go into glaucoma? Or all patients are likely to go into glaucoma? So blunt traumas, and which kind of blunt traumas? Bolo. So if you have hyphema, okay, and the extent of the hyphema is large, and the intraocular pressure is above 50 millimeters of mercury, it's unlikely to be controlled on medical treatment alone. Okay, the chances that this eye will go into glaucoma are very high compared to, let's say, another one where the trauma was not so severe. Maybe you didn't have much of hyphema. It was just a little bit of mydriasis, and that's all. So the severity of the trauma is directly proportional to the later development of glaucoma. That means if the trauma has been extremely severe, which has led to hyphema, which has led to maybe a dislocation of the eye, of the lens, it's likely that that particular patient is more likely to develop traumatic glaucoma. Okay? So if a patient comes to you in the OPD or with trauma and 50 pressures, unlikely to be controlled medically, will require surgery. Okay? Just take it as a rule of thumb. So here was a patient, high pressures, hyphema, and what do you see on the angle? You see some amount of angle recession here, yes? And you see some amount of clots here. Okay? So sometimes when in a particular unilateral case of glaucoma, you just can't find the diagnosis, just put in a gonio lens and you will find your diagnosis there. So this was one such case where, of course, on anterior segment imaging, you could find the mydriasis and then again, of course, angle recession glaucoma. And management? Absolutely. Okay. So trabeculectomy is a good option in patients with traumatic angle recession with secondary glaucoma. Yes. Okay. Now, he is a young person again with who's a tailor, and now he's complaining that he could do some work earlier, his near work, but now he's not able to do that. And he was prescribed very thick glasses, he said, even with which now he cannot work for near. So the glasses that he's been prescribed are -14, and he's only left with like 1/60 vision in both the eyes. Can you come to a diagnosis seeing this picture? Yes, very good. Now let someone next to you answer. Come. You want to take the... It's not very difficult. Oh. Yeah, there is myopia. There is myopia. Okay, someone else behind the girls. It's not so difficult. Just look. What is the anterior chamber depth here? Young person, high pressures, myopic, shallow anterior chambers. What could be the diagnosis? Bolo? Come on. अब पता लग गया या अभी भी नहीं पता लगा? ठीक है? secondary glaucomas following a spherophakia. This is his cup. So he's just losing vision all this time. He's been having high pressures, 50 pressures with this. So what is the what is the management? Management? Lens extraction. Okay, the lens has to be out. So not only in this condition, any condition which causes where the lens is causing the glaucoma, the lens has to be out. Angle closure glaucomas, spherophakias, classical indications, phacomorphic glaucomas. Okay? But as a rule of thumb, glaucoma takes precedence over all the other conditions, whether it's a corneal condition, whether it's a retinal condition, whether it's a squint. If the pressures are high, the pressures have to be managed first, because once the optic nerve goes, the story is finished. And I'm going to tell you this in the next example. So here is another male who presents with 35-year-old male presents with high pressures in both the eyes, poor vision in his left eye. Young male, bilaterally he comes with high pressures, shallow anterior chambers, corneal edema in the left eye, 624 vision in the left eye. What is the diagnosis? Now the residents in RP center could know this, so I would want you to, some intelligent person to just raise up their hands. What is the diagnosis? You cannot miss this. Bilateral, young person, bilateral. Huh? So this is a case of, he was taking some drugs. Vernal catarrh, 35 years of age. Very good, she said it. Stand up, tell them. Topiramate. Okay, there's a fusion. Okay, and management. So a patient who is young, who comes with high pressures in both the eyes, some amount of corneal edema, there's only one thing that you can think of, and that is topiramate. Okay, you take a history of any drugs that he's taking systemically, right? So what do you do for management? एक आदमी बोल दे, आप बोलो, you know. चलो ठीक है, pressure lowering, but what is the actual management? What is the? Anyone else? You tell me. Okay. Well, the stopping the immediately you have to lower the intraocular pressure. So as he said, we have to lower the intraocular pressure, isn't it? The effect of obviously the patient is now the patient is in front of you, and stopping the drug, and then the effect will take. Abhi immediately क्या करेंगे? You just put 2 or 3 drops of something, and which drug? Very good, cycloplegic. So you basically have to give them cycloplegic. So there's one indication where the AC is shallow, and you can give cycloplegics and abort the attack. Okay. Now this is a elderly male who comes to you with is diabetic and comes to you with a PDR. Anterior segment looks pretty good, right? But his right eye has high pressures and advanced cupping. Okay. Now you put in a gonioscope. What do you see? NVI. Okay. So this is a, what is it? It is an open angle. Can you see the angles are open? Yes? But majority of the NVG patients that come to you will have closed angles. So 95, 96, 98% will be angle closure glaucomas, the ones that come to us. It's very rare that you get an open angle stage of neovascular glaucoma. Okay? So if you see an open angle stage of neovascular glaucoma, how do you manage it? That means you were intelligent enough, you picked it up early, and now you have to decide how to manage it. Okay, PRP, anti-VEGF, very good, excellent. So this is one group of NVGs where you can get away just with a anti-VEGF or with a PRP, and generally this neovascularization will subside and the IOP might come down. Okay, But as a rule, the 98% of angle closure glaucomas with neovascularization that come to you will have to be managed with a surgery, a glaucoma surgery. Okay? You do not wait for a PRP, or you do not wait for the effect of the neovascularization to regress. You have to manage the intraocular pressure. As I said, the glaucoma takes precedence over anything, whether it's a corneal disorder or a retinal disorder or a CME or whatever. So you have to manage the glaucoma first, and something else later or can be done. This patient came to us, relatively normal looking anterior segment with advanced cupping in his right eye. This is the gonioscopy. We couldn't find out why he had unilateral high pressures and glaucomas. So we put in a gonioscope. Can you see something abnormal here? Can you see it now? So, what is it? This is a nodule. Okay, then we carefully looked at his anterior segment. And we started finding nodules on the iris. So, what is it? What is it? Neurofibroma has diffuse nodules all over the iris. This has one single nodule on the angle, one single nodule on this. Which kind of nodules in uveitis do you see like this? There are two types of nodules. Busaka nodules. Okay? So you have sometimes very carefully examine. On cursory examination, you may not see anything. Again, you put in a gonioscope, you see that there is some amount of a nodule there in the angle, and there then you start clicking that probably this is some kind of uveitis going on which is causing the secondary glaucomas. Okay? So again, the glaucoma has to be managed. Post-uveitic glaucoma, the glaucoma has to be managed. If a patient comes to you with anterior chamber inflammation, yes, this is no activity here. But if a patient comes to you with activity, there's uveitis, anterior chamber cells, flare, high pressures, what do? You manage the inflammation first, yes? The IOP is high, but you still have to give them steroids. You still have to give them cycloplegics, because there's a possibility that if you give them steroids, cycloplegic, the inflammation comes down and the IOP also comes down. But there is another possibility that it may not come down, in which case then you have to go in for a surgery. Sometimes even in a hot eye, with inflammation and all, you may have to go in for the surgery, because as I said, the optic nerve and the high pressures will take precedence for management. Okay? You will not wait for those 40, 50 pressures to go on and on and on and damage the optic nerve. So this is the story about the uveitic glaucomas. Now to sum it up, to round it up for a quiz for the residents. Diagnosis. बोलो बोलो, आप खड़े हो जाओ, जोर की बोलो. Pigment dispersion syndrome. Yes. What is the management? High pressures. Patient has high pressures. Pardon? PI. Who said iridotomy? So this is one kind of glaucoma where they say there's a reverse pupillary block. There's a concave configuration of the iris, and the pressure in the anterior chamber is higher than the posterior chamber. So by doing a PI, you can equalize the pressures and probably decrease the pigment dispersion. But I mean, no longer does this particular hypothesis hold true, and people no longer advise PI for pigment dispersion. But what can you do apart from PIs? PIs doesn't do much. SLT is ideal in these patients, okay? And if that doesn't help, then of course you have to do a trap. But what if this was not a bilateral case? What if this was a unilateral pigment dispersion like this? What comes to your mind? What is the differential diagnosis? Pardon? Ocular? Okay. Maybe before some surgery may have been done, and that is why he's had pigment dispersion. Or anything else? Trauma. Anything else? Unilateral. Lot of pigment in the angle. What's high pressures? Postno-Schlossman, uveitis, yes, maybe uveitis. But such kind of pigment, if you see such kind of pigment, melanomas. Okay, always have that at the back of your mind. Lot of pigment in the angle. There might be a ciliary body melanoma if it's a unilateral condition. Again, you have to be very careful. Okay, this is a diagnosis that's staring in your face. Tell me. This patient didn't have high pressures. He had low pressures. Very good. Excellent. So this is an angle recession, and here you can see that the ciliary body is disinserted from the sclera, and therefore you can see that wide ciliary body band and then the sclera because of cyclodialysis. So here you have to just repair the cyclodialysis and bring up the pressures. This is a very interesting case that I was operating about half an hour back. I've come from the OT and I took this picture. So I finished the trab in this patient who had uveitis and very high pressures. And as I was trying to give a subconjunctival injection, I found, can you see these black hair in the subconjunctival space? I mean, this is, and I had never seen this before. The entire subconjunctival space has these small hair, and I was wondering, where have they come from? And then the patient said that, you know, when I was a child, I had a caterpillar going into my eye. So these are those caterpillar hairs, and suddenly we realized that they were causing his uveitis and the secondary glaucoma. Okay, so this is, I just took this picture half an hour back, and I told my resident I have to show this picture because something very, very rare. I had never seen it in my entire career, where you know, the caterpillar hair had caused uveitis and then the secondary glaucoma. So that is that. So basically, secondary glaucomas, if you go through the textbooks, everything is covered. They could be because of corneal conditions, retinal conditions, uveal conditions. They could be because of lens-induced. So, but then as I said, the management is very simple. I mean, you just have to talk about three things: trabs, tubes, and cyclophotocoagulation if the prognosis is not very good. And you can sum up your case very easily. So any questions you have regarding these cases, I'll be happy to take, but pardon? I did. That is why I was late, because I in the OT, I have been removing these hairs, and I was shocked. I mean, I have never seen this before. I mean, all of it. I was just trying to give subconjunctival injection, and then I saw the hair were lying all over the place in the subconjunctival, and you have to tease them out from the tenons, you know. I mean, it was very strange. Pardon? Oh, into the eye? And causes uveitis? No uveitis.
Yes, can cause uveitis. It can penetrate. Yeah. Yeah, it can be quiet too. Yeah, I suppose the liberation of toxins.
I've never seen this, so it was very strange.
We see a lot of caterpillar hairs,
Yeah.
but
Thank
not this. Quite an interesting gamut of cases.
Thank you.
Thanks, Dr. Vinay Gupta. Thank you. I just want to request you all not to take pictures because you're getting the PDF and other copies of the presentation. So don't waste your time taking pictures. Let the photographers do their job. And next I will be talking on some glaucoma cases. Oh, okay.
Yes,
While she does this, I request you all to make this interactive. I shall be, whoever wants to answer, please raise your hand, right or left, and we will interact. Okay, whether you want to ask or tell or answer, please do that. Let there not be much chaos. So,
the first two rows are hot seaters, so you can ask.
oh, you all are
anybody
hot
on-
seaters, I never knew.
Yeah.
But anyway, even the backbenchers can do a good job. How's the thing? Okay. So we'll talk about some glaucoma cases. And the first one is a combination of open angle glaucoma and neovascular glaucoma, 2 in 1 case. I wonder if you already guessed the primary diagnosis. Can I ask one of you, either the hot or the cold batch? Yes. Please tell me what is this? What is the hidden diagnosis here? The next person, quick. Anybody? 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 Okay, then we'll keep the suspense on. Oh my God, where is this? How does this go? Enter. Okay. So this is a case with acute, the diagnosis is still coming. Acute loss of vision in the left eye. This is the, say that again? CRVO. So that's the diagnosis. So whenever there is an acute, painless loss of vision in an older person, all things equal, whether you have diabetes or no diabetes, age is an issue. So age is not on our sides. So we need to think of this, and that was indeed the diagnosis with a very poor vision in the left eye. You should have guessed it in the first instance. You got a second clue. Anyway, what history we take? We know we take history of comorbidities, ischemic heart disease, and why? And in whom do we take history of vasculitis? Yes? Anybody? Young people, young CRVOs, we need to take history of vasculitis. So I'm just digressing a little because, glaucoma doesn't really, have borders. It is without borders, a disease without borders, and the artificial compartments we have created is not for glaucomas. Okay, so vasculitis, blood dysplasias, hemophilia should be in mind in a young patient. Now, what is it missing from my history? Can somebody tell from that side? Anybody? Quick. I don't want my time to get wasted. Anybody who knows, raise your hand. If nobody knows, that's very sad. We should ask history of open-angle glaucoma, and all of you should make it a point to do so, because many patients, in fact, 10% of vascular occlusions have glaucoma, features of open-angle glaucoma. Now, ocular examination, all of us know, we have to see the anterior segment, we'll have an RAPD, so this is beyond, this is retina, so we'll not talk much about it. But what's important is to look at the iris for new vessels. Why do we need to look at the iris for new vessels? Next, anybody? Because that is the earliest sign of neovascular glaucoma. And which study has shown that this is an important sign to do photocoagulation? Which is a study? Yes, who is that person? CVOS. Okay. So please remember, these things are all important. We go by guidelines are made by randomized trials. So we need not do a prophylactic photocoagulation just by seeing a CRVO. We need to wait for this, and at every follow-up, we need to look for new vessels on the iris. So this patient had sedal scotoma in the right eye, and now with the fundus shows advanced glaucomatous cup both eyes with superior and inferior thinning, and a battlefield fundus in the left eye, quite obviously due to CRVO. And which type do you think it is? Ischemic. Okay, but what is not there? Anything important which is not there? Very good. Cotton wool spots are an important sign of ischemia. Not that if they're not there, it's not ischemia. Okay, this is just one of the signs. Now, so what is the full diagnosis? Anybody from this side can tell a full diagnosis with this case? Because quite often you people jump to the positive thing and miss out the full diagnosis. One person stand up and tell the full diagnosis. Not that difficult. One person, please. That's how you're asked in the exam. Sorry. I've given you all the findings. In fact, I've given the diagnosis before I even started. And that is also a very practical thing, because all of you get the diagnosis in the exam. Somebody whispers it to you. Isn't it? So that is the diagnosis. You have to say that's the primary thing, open angle glaucoma, both eyes, with ischemic central retinal vein occlusion and cystoid macular edema in the left eye. Okay, so we have all the features, and I did tell you that 10% of our RVO patients have some kind of features of open angle glaucoma, and the other way of looking at it is open angle glaucoma has 5 times risk of retinal vein occlusion. The rest is retina. I will not go into it. What is the role of FFA? In the initial stage, do we do an FFA? No, we don't, because all you get is blocked hemorrhages. So we do it much later if we need it. So these are all to confirm. And how do we evaluate ischemia. Do you know any new technique, new modality to evaluate ischemia? One person, put your hand up. One person, put your hand up. We can't hear. Yes. OCTA, yes. That mostly does for the macula, isn't it? Anything even, maybe even better for now? What is this? What is this? Hello, what is this? Ultra wide field FFA. Because we're talking about the peripheral retina. This gives normally you have a montage view, but this gives a wide view, and here you may not, with the regular one, you might underestimate the CNP areas. And how many CNP areas normally? Yes, that you know. So here you may detect it earlier, and this is useful also in which other disease? PDRs, in diabetic retinopathy as such. And soon the guidelines will change based on this modality. Now, what is the relationship between open angle glaucoma and CRVO? It precedes and promotes CRVO. By the high IOP causes retrodisplacement of the lamina cribrosa, distortion of the veins which go over it, and also at the rim of the cup. And there is stasis and resultant occlusion in an already prone eye, which is older individuals. Now, this open angle glaucoma with the cupping, loss of support, and along with high intraocular pressure, compresses the vein. And this shares the CRVO and open angle glaucoma share a vascular pathology also. And there is a mechanical risk factor. So pathobiology also has a lot in common. Now, management. We mustn't forget that open angle glaucoma is the primary culprit, and it must be treated in both eyes. In fact, the anti-glaucoma drugs, the better eye, that is the right eye in this case, should be preserved, because in the end, that may be the better seeing eye, finally. The CME, I will not talk about it, not in the purview of this talk, but CRVO follow-up is very important, and you must look at each time you must look at, what do you look at each time in the follow-up? One person only. Yes, please tell loudly. With slit lamp for NVI. Anything else? Anything else? Hold on. You must do a gonioscopy also. Each step you must do a gonioscopy simply because you may miss the new vessels. 10% of the neovascularization may first appear in the angle, and therefore it is mandatory to do both. Then then depending on the situation, we may do a PRP as per the CVOS study, or nowadays you can use the anti-VEGF. Now this patient will have none of it. As often we see, most of them take one injection, nothing has happened, why should I keep going and paying money? So they stay home, and then they come back after a couple of months with high intraocular pressure, and here the diagnosis is NVG, neovascular glaucoma. Now, so here are the findings: very high intraocular pressure. Most often they have some signs of iritis, or maybe even moderate iritis, mild to moderate. And the other way of looking at it is, when you have a case of uveitis, unilateral, particularly in an adult or older person, look for new vessels. You may miss it otherwise. Okay, so this will mimic a uveitis sometimes. Of course, there can be RAPD because of the occlusion behind. Ectropion uvea may or may not be there. It's a classic finding, though. And then you have new vessels all over the iris, as also a membrane in the angle. As quite often we see the closed stage. Sometimes we may see in the open stage, as Dr. Gupta said. So now, what is the relationship? Another thing which we must know, sometimes we should know statistics. 30% of neovascular glaucomas, or 1/3 of neovascular glaucomas, are due to central retinal vein occlusion. What is the other 1/3 due to? PDR. The other 1/3 is due to PDR. So it makes up more than 60–70%. And then we are left with ischemic syndrome and other CRAOs and other less common things. Okay. So what is the role of anti-glaucoma agents? They are not very good, especially when there is a closed angle stage, and it is restricted to beta blockers and carbonic anhydrase inhibitors, and prostaglandins and pilocarpine are a no-no. Okay. We need to use cycloplegics and steroids topically for the attendant iritis or uveitis. And then what is the role of anti-glaucoma agents? Yes, the one with the yellow, orange. What's the role of anti-glaucoma agents in your mind? In intravitreal, anti-VEGF. Intravitreal anti-VEGF. We discussed, no, we can give it. CRVO is there, neovascular glaucoma, nowadays it's just given. Louder? No, you first tell me, I don't want a discourse. I just want to know, is it useful, not very useful, can't say. Useful. Very useful? Very useful, not so useful? What is it? Not very useful, by the way. Simply, the last speaker said, no. At once the zipper stage happens, that is, there is a angle closure, that neovascular membrane cannot be trespassed by any power except surgery, okay? So you can, the new vessels will reduce. In the open angle stage, it may work, but when it's a closed angle type of neovascular glaucoma, it has much less of a role. You may give it just to reduce the further proliferation, but don't expect it to work wonders, definitely not. Okay, so more often than not, you will need surgery. And here it is either trabeculectomy with MMC or shunt. Which will you prefer? And based on what study? One person, yes, the violet. All the girls are sitting in front. So, you will prefer shunt surgery. Why would you prefer shunt surgery? Shunts. What is the practical difficulty with TRAB and MMC? What is the thing? Is there a study to tell you that? What is that study? TRAB versus? Who said TRAB? Can you rise, please, and tell us more about it? Which TVT are you talking about? Yeah, I know. There are two. There is one PTVT. What's that? That is primary TRAB versus tube. Of course, you're right. This is the ordinary TVT, which was done earlier. What was the inclusion criteria? But this is not this, I mean, the neovascular glaucoma was not necessarily the inclusion criteria. But that was the first study to show the worth of tubes, of the AGM, I mean, glaucoma drainage devices. And of course, it didn't necessarily include neovascular glaucoma, it included failed TRABs. And it did say that this is better than TRAB. Please remember, with such a angry vascularized eye, TRAB is not that simple. Okay, especially when you have to do an iridectomy also. You have to choose a site which is not too vascular. All right, so shunt procedure is good. Please read about primary tube TVT. I will not tell you now. So then, finally, you may have to do a cyclophotocoagulation or any of the destructive procedures that you have. That does not mean you neglect the fellow eye. Quite often it happens. Everybody is concentrating on this acutely ill eye, so to say, and we neglect our fellow eye, which will ultimately have better vision. And so we may do all that we can to get the target pressure, follow up closely, and what patient is going to ask you is, what is the risk for this eye? This has happened, what's the risk for the other eye? What will you say? Say it from what I've written, okay? So the risk is as high or as little as any other case. There's no study to say whether it is higher or lower. Sometimes we have to be very frank, it's not that it's nil. It is around 3.2% per year, okay. So that is case number 1. Oh, am I going too fast or too slow? I do not know. Now next, we are again telling you the diagnosis. This is because you always have the diagnosis in hand when you're having the exam. Somebody whispers to you, right or wrong, and so you always have it, so I'll give it. But that is not to say that we cannot examine your clinical acumen and your thought process. Your thought process is what we should be examining during practical. So, and that the diagnosis is, it just comes in, walks in, if you have the right thought process, okay, and without any bias. And because you've been told the diagnosis, you often have that bias, and you're unable to answer many questions. But I cannot say you don't get the diagnosis, because you will get it, okay, and that life will go on. So anyway, this is a 65-year-old person with painless loss of vision in the left eye. It is anybody's guess, it could be anything. But we must, whenever there's a unilateral problem, you must ask for history of trauma. But don't keep asking history of trauma as a ritual in every case. Bilateral, everything you all say trauma. It is just for time pass. But that's not, even a wrong history it has discredit, okay? So we should not just ask history of trauma, because everybody will say they had trauma. Yesterday they fell, something. And those who have long-standing trauma always forget it. And just in the morning, he told you about traumatic glaucoma. The trauma haunts you all the time. Once a trauma, always a trauma. So in a uniocular case, it's a very relevant question, not so in bilateral. Now, clinical examination is here in front of you. Right eye is more or less normal. Left eye has subnormal vision, quite subnormal, with an RAPD. And you know the diagnosis, so there is transillumination, and intraocular pressure is very high. There is pseudo-exfoliation in the pupillary margin. Where else will you see the pseudo-exfoliation? Yes, somebody next to the orange person. What's your name? Harish, where are you from? Huh? Vision Eye Center. Okay. Tell me where else will you look for the, before the angle, first see the slit lamp, yaar. Huh? Pupil margin is over. That I have seen. You must dilate the pupil and see, okay? So just as I told you, slit lamp, pupils without dilatation are important as after dilatation. Don't get your optometrist to see before dilatation, you will see after. It doesn't work, because you will miss two important conditions which we have talked about today. What are they? Pseudoexfoliation and NVI. So please examine before dilatation and after dilatation. You have to see the fundus, you have to see all the other zones, all that, and so on. So then you have there's 0.8 cupping in one eye, and it's normal in the other eye, and the fields were showing small, extensive loss. So that is the pseudoexfoliation. And here is, what is the arrow pointing to? What is the arrow pointing to? Yes, the girl with the black dress and knife flowers. Louder. That is showing wait, hold on. Why does that occur? Louder. No, it's simple. Even in why will iris atrophy simply occur? Why does it occur specifically in this pseudoexfoliation? It doesn't occur in open angle glaucoma. Even in uveitis, you don't get transillumination. There you get marked iris atrophy, isn't it? What happens? What happens? Anybody? Anyone? Yes, tell me. Oh, that is in angle closure. It is not an acute rise. Ischemia and acute rise are in angle closure glaucoma. Even there you don't see iris atrophy. You see iris atrophy but no transillumination. Here it is because of the exfoliation material which rubs as it plays on the anterior lens capsule. The posterior surface is pigmented, and then it loses the pigment because of this rubbing. And once that happens, the transillumination shows through. And these are the two zones, central zone and peripheral zone, which you must know. So transillumination defects are very typical. And then 5 minutes, yeah, 5 minutes, no problem. Okay, so there is extensive advanced glaucoma in the left eye. Okay, you're seeing that, and this arrow shows bayoneting. Okay, there's hardly any rim. There's peripapillary atrophy, advanced field defect in the left eye with just a small central thing. What is the significance of that? The one in green. Hello. You're sitting in front. Tell me what is the significance of this in this case. Such an advanced field defect is quite unnerving in any case, for that matter. In this case, even more. Advanced field defect is good or bad? First you tell me. Bad for the patient, isn't it? Then why is it bad? Is the next question. And next person. Tunnel vision is there, I know. So what? Why is it bad in terms of management? Yeah, it's bad for the patient. That's a given. Louder, one person. Oh, it's irreversible, or can be made worse. Yes, so quite often in such cases, we might contemplate surgery. So this is a bit of a problem because there can be a snuff out after surgery. But if there is going to be a snuff out all the time, we'll not be doing surgery, isn't it? Then why do we do? Why do we do surgery? I mean, when can we predict it? Yes, you have to check for macular split, very good, by doing a 10-2. Then, one more thing, which makes them vulnerable. There are certain risk factors. One is age, older the age, and also acute hypotony after surgery. Post-operative hypotony may also have this risk. So it is a calculated risk and must be explained to the patient, and we must do a 10-2. Gonoscopy, you know that. Can you describe the angle, one person next to you? Quick, describe the angle, because all of you jump to the diagnosis like that. Well, there is less time. It is first you must say it's an open angle. Then you must grade the angle and say which grade? Grade? So you must not only say 3, 4, you must say whose grade, because 0 is closed in one and open in the other. So you must say all this and then talk about the sample-asis line. Okay, doesn't matter. So this is the most common cause of secondary glaucoma and the most common cause of unilateral glaucoma. Please remember, okay? And it is often and very advanced to start with, simply because, I'm not asking because there's no time, simply because this is unilateral and the patient doesn't realize because he has good vision in the other eye, and also because this pressure has a different modality compared to open angle glaucoma. It fluctuates. The highs and lows it can have very high peaks and doesn't follow the biphasic curve, which we normally see. Therefore, it eludes the medicines. So we often do not get the peak with whatever medications we use. And even then, because of the peaks, there is optic neuropathy, and that often presents as a late glaucoma. And please remember, this is a gene expression of a LOXL1 gene. We'll not talk about it much, but remember it is a multi-system disease. Affects the heart, lungs, kidney, liver. But unfortunately, it just licks these organs or just tickles these organs, but it bites the eye like none other. So treatment, I told you medical treatment is a little difficult simply because of the fluctuations we may not get, and more often we start with true drugs in this case. Normally the principle of glaucoma treatment is start low and go high. Start minimum medications, minimal frequency. But here we break that rule and start 2 medications probably in the first place. Role of laser, anybody can tell? Role of laser? Anybody anybody there? Good, bad, very bad, can't say, no good. It's very good to start with because of the pigmented trabecular meshwork, but in comparison to open angle glaucoma. But with time, the pressure rises simply because the condition is continuing. The pseudo-exfoliation material continues to be formed and it continues to block. So it is finally it evens up and becomes worse than open angle glaucoma, okay? And then we are left with surgery, and there we must do the this 10-2, as I already told you, and the differentials of unilateral glaucoma: Fuchs, unilateral, young, with cataract, stellate capies, and mild intraocular pressure rise. PAC is a subacute, or the variety which is a creeping type is often uniocular. The clue lies in the fellow eye, which will be shallow. Okay, this is actually a bilateral disease which will present in one eye first. Angle recession we already talked about. NVG we already talked about. And uveitis, often the glaucoma and the uveitis are also present in both the eyes. Rarely it can be unilateral, and you will see all the signs telltale signs of uveitis and steroid glaucoma. Thank you.
Thank you so much, ma'am. So these are the lessons that go with us always, as I said, that the discussions always matter because we hold on to them because there's always a story behind it. Thank you so much, ma'am. Thank you. So we move on to the next part. So how many of you are excited about coming up on stage? Right, so this is the Grand Viva competition session. So the ones in the audience, let me tell you, this is useful for you as well because the camera has been adjusted in such a way, even for the ones online, we want you to take maximum out of this. So this is like a glimpse of what's going to happen in your Viva. So you sometimes at Viva, you might just be like this close to having a heart attack as well, and that happens. I'm sure I had my worst day that day. Like when I gave my Viva, I was like, okay, I'm gonna die, I'm sure. But like, you know, okay, this is what's gonna be like, what it's gonna be like. So as we say, this is the trailer, and there is more to go in the movie. So, so out of the ones who sat down over here during the lunch hours with all the hard work that they put in, yes, okay, like a special mention I have for 3 people who were like, you know, this close to being there. So we take usually 6 participants, but this time we're going to take 5 because at the 6th position we had a tie of 3 people. So I'm still going to give you guys a special mention. So that was Dr. Gautam, Dr. Niharika Chaurasya, and Dr. Vipin. Okay, so you guys were at the 6th position. Get up, acknowledge yourself, let people know. Okay, the lights went off. As they rise, the light went off. Yeah, okay, fine, go ahead. So these 3 did very well. You were this close, but we had to eliminate the 6th position because there are 3 of you. We can't have 3 heart attacks happening up there. Okay, so we move on to the next people. Sorry, ma'am? 3 more. So I'm going to go in the order of 5th to 1st, all right? So the names are Dr. Agrima Bhatia. Get up and acknowledge yourself, yes. Perfect, great. And Dr. Shrishti Kular. Perfect. Dr. Anurag Kumar. He's so upset. Has anybody been so upset? Like, oh my God, I have to be drilled in the Viva now. Dr. Aishwarya. And the one who got the maximum marks was Dr. Nishi. She's also looking upset. Don't worry, you got the maximum. You scored 12 out of 15, so that's an excellent score. All right. And I was quite impressed while correcting it. So, great. So, while the stage is being set up, let me introduce you today to the judges today. And our expert examiners for the day would be Major General Dr. J.K.S. Parihar, sir. And he is the senior consultant and head of academics and training at CFS Delhi. And as I mentioned earlier also, that he served in the armed force for over 34 years with distinction in the rank of Major General, which is the 2nd highest rank for any doctor. Please maintain a little bit of silence, please. Because, you know, it kind of goes as ruffled noise in the live sessions. Okay, and we have with us Dr. Bhavna Sharma, ma'am. Welcome, ma'am. She is the professor and head of department at AIIMS Bhopal, and she's come all the way for just one day to be with you guys and with like early morning flights. Thank you so much, ma'am. And next we have with us Dr. Kamaljeet Singh, sir, and he's a professor at Regional Institute of Ophthalmology, Allahabad. Welcome, sir. Next we have with us Dr. Suresh Kumar, sir. He is the professor and head of ophthalmology and GMC Chandigarh. Kirti Singh ma'am is on the way, so she'll be joining us soon. And we have Dr. Murli Manohar, sir, And he is the consultant, and he's basically the senior professor and head at SPMC Bikaner with 28 years of experience in ophthalmology. Welcome, sir, and thank you for traveling for such long hours. I know that Bikaner does not have a good connectivity, but thanks a lot for turning up for us, sir. And we have with us Dr. Renuka Srinivasan, ma'am. Now is right here. I'll just get back. So you have already heard from her. So she is the professor of ophthalmology from JIPMER, and I'll just get back with her. Over to you, Vanita ma'am, our anchor for the day.
Thanks a lot, Rolika. Excuse me. Yeah, so while they're setting up and whilst each one of you will call, there are two things that occurred to me. Yes, please, I want a connection. One is with pseudoexfoliation glaucoma or pseudoexfoliation itself, remember that they also get deposited on the zonules. You don't get to see that, not unless you're doing an endoscopy, but that can cause angle closure. So you need to do a PI. So all pseudoexfoliations are not open angles. All right? Don't assume that. Please do a gonioscopy. And the second point, I forget now. It'll come soon enough. Yes, please. Thank you.
I just forgot to introduce the deadliest and the friendliest examiner, and that is Dr. Rashmin Gandhi, sir. And he needs no introduction. He's right here with us. And over to you, ma'am.
Thank you. Well, guys, are you ready? Who's coming first? Rolika. Yeah, the sequence, please. Dr. Nishi, can you please come onto the stage? So she will be presented, with anything that is on the table, which could be a bottle, an instrument, a printout of, say, the disc or the HVF or, a fundus photograph, anything really. Come on, Nishi, take your seat. Please give her a big round of applause. It takes great courage to come up here.
I would like to simply say that we are just your friends, so don't be nervous. Okay? And most of the examiners try to get you the maximum marks. We are all very lenient examiners. Okay? So we'll be asking just very, very simple questions. What is required for MS degree? No difficult questions, no difficult problems. Okay? So I'll request Dr. Parihar to please first.
Generally, when you have a test match, you start with the bouncers and pace bowler. But I am not a pace bowler. What is this?
Show it in the camera. So the others see, no? Show the tip or something.
Yeah.
Yeah. Go ahead.
She needs a
You
mic,
can,
please.
mic. You can use this mic.
Hello. This is a corneoscleral scissor, and it can be used for peritomy, either by,
Why have you said it is corneoscleral scissor?
sir, because of the cutting tip. And
Can't it be used for conjunctiva?
yes, sir.
What is not tenotomy seizures?
So it describes seizures. Then you interpret it whether it is a corneoscleral seizures, it is a curved seizures, that curved tapes, sharp tape or blunt tapes. The action is slanting actions or crisscross actions. What is difference between this seizure and DeBaker's seizure?
Sir, the angle, the curvature will be more in DeBaker.
Have you seen?
Yes, sir.
Because it's now outdated. But this is a good one in comparison. Did you want this one?
No, it's okay. You can.
Yeah, this is to compare.
instrument, you first hold that instrument and you start describing it, whatever you know about it. Like, what is the instrument? Is there a name given to the instrument? In what surgeries it is used, and what step of surgery it is used? Any advantage associated with the instrument? Any disadvantage with associated? So once you say the complete thing, there are very less questions which can be asked to you. So say for this scissor which you are describing, you said it is a corneoscleral scissor, and you said you want to cut conjunctiva with it. So that is the discord. Always describe the instrument in totality, in completeness. So maybe you would like to describe it now better.
Is it right or left corneoscleral Caesar?
Or universal?
Anyway, I think you have done extracapsular surgery? When have you seen using this scissors? When have you seen it being used? At what step? Which surgery?
Ma'am, for example, if we are
Just one surgery you tell. Don't have many.
Ma'am, ECC. If
BCC we are not doing, so even if you tell, we won't believe it. Okay, so yes, that was classically used for that, but which is the other surgery where it is still relevant? If it is not relevant, we won't keep it here, isn't it? Which is the other surgery where you have to cut the cornea? Which is the corneal surgery? Which is the corneal surgery? Which anybody is doing? Yes, it is used in penetrating keratoplasty. Thanks.
I'll just take a minute out here. Please note the points that the examiners are asking. That was very relevant what Dr. Bhavna said, okay? All those points are important. That is how you need to answer in an examination to impress the examiners. Sorry, carry on.
What is this?
So that others can see.
This is a macular OCT and an optoview OCT, and the patient's details are mentioned above. The signal strength
What
is,
OCT is it? Spectral domain, time domain, enhanced depth? What is it?
this is a spectral domain OCT, ma'am, and it is showing, we can see the layers of the retina in this, and there are large cystic spaces in the internal retinal layers which are seen, and the RPE complex looks okay, but there appears to be some amount of IS-OS junction disruption. There are some amount of hyperpigmented foci which are seen in the internal retina.
The spectral domain, can you really see the IS-OS? That's why I asked you.
Ma'am, it is...
What type of OCT is normally required?
For the RP, ma'am, RP Brooks membrane complex, inner segment, outer segment, ellipsoid zone.
Okay, what's your diagnosis in this?
Ma'am, it can be a cystoid macular edema if we have some history. It can be either due to diabetes mellitus, so DME, or it can be due secondary to BRVO, CRVO, as appears on this image, ma'am.
You see, when you describe OCT, you must tell what exactly, I mean, you should first tell pre-retinal area, what do you see there? Then on the retinal surface, what do you see any epiretinal membrane or not? So you cannot jump directly to the macular edema. Okay, so you have said that cystoid spaces are there. So in the macula it's there. So then you come on to the intraretinal area, and then you go to the subretinal area. So if you go like this, you will not miss anything, and examiner would know that this is the way. The epiretinal membrane many a time we miss because you have some macular edema associated with that. And then you have to see the fundus picture also. Here you can see there are some hard exudates. Okay? So if you get a good fundus picture, that is better. So you can always say that, sir or ma'am, I would like to see a fundus picture of this. A colored picture would give me more findings, and I'll be able to exactly pinpoint the cause of the cystoid macular edema that is there. Because there are so, what are the causes of cystoid macular edema other than what we have enumerated?
Other than the diabetes.
You have said diabetic retinopathy, BRVO, CRVO, anything else?
Mic to be in front of the mouth or close.
If this patient had night blindness,
So, ma'am,
Retinitis pigmentosa.
retinitis pigmentosa and optic disc pit can have.
this pit causes cystoid macular edema. What does it cause? It is related to what disease?
Retinoschisis.
No, it's related to what disease?
Other
Not
CSR. ma'am.
CSER. Not this.
CSER.
Okay, there you'll have a SRF.
Yes, ma'am.
Subretinal. Okay.
So what do you do for this?
This patient can be given anti-VEGFs.
What other things can be given apart from this anti-VEGF?
There can be Ozurdex implants, steroid implants, and triamcinolone, according to the
Okay,
study.
what is the problem of triamcinolone?
Sir, it raises the IOP and it cannot be
In how many
explanted out.
cases? What is the dose of
4 mg per
0.05 ml? Have
in
you given
0.05. No, sir, I have not given triamcinolone.
it? Good.
Can anti-VEGF may lead to edema?
Macular edema, sir. I'm not sure of any studies
कितने
which is.
बच्चे हैं कितनों का एग्जाम लेना है? So how much time for each candidate? Okay.
Just one comment for you here. Whenever you are describing any specimen like this, you should first see the specimen, which instrument, which view this belongs to. Then you identify the structure either from anterior to posterior, from outside to inside, from superior to inferior.
Yes, ma'am.
Identify the normal areas, identify the abnormal areas. You cannot jump on to say that there is a cystic space and do not identify the normal, the temporal side of that.
Layers.
So should you miss that, your Viva would be drifted to that part, like the disc pit and all these things. Okay. So
And-
follow a pattern while describing, and you can direct your Viva to that part or that portion where you are well versed with.
And the
okay?
basic principle of OCT, right from the full form of the OCT and the basic principle. That should also be known to the candidate, because sometimes we start with that only. Diagnosis is the last. If you miss the diagnosis, not a issue. The concept should be clear.
And I think she also missed the eye. Which side? Laterality.
The eye, the view, the type of the investigation it is, everything should be, then you go on to, you cannot jump on to the diagnosis and the pathological findings.
Yes, ma'am.
Identify if there's anything normal in that, okay?
Yes.
Right, before the next question, sorry, can I just introduce Dr. Kirti Singh, good friend. She's professor, head of ophthalmology, does glaucoma as her subspecialty at MAMC right here in Delhi. Welcome.
Take this.
Sir, this is.
Show. If possible. Yes.
These are tropicamide eye drops, 1%, and these can be used for.
It is of which group?
It is a-
Sympathomimetic or sympatholytic?
It is a anticholinergic.
That
sir,
is called as?
parasympathomimetic.
Yes, good. Parasympatholytic. Yes.
Ground level पे नहीं आ रही है.
Lytic, sorry.
हाँ.
Sympathomimetic.
Sympathomimetic.
Parasympatholytic, which has similar action to sympathomimetic.
That is other thing. So,
Yes,
they are
sir, yes,
different
sir.
actions.
Different actions.
Yes,
Yes.
sir.
They are not same.
Yes, sir.
Sympatholytic, obviously, will be the source, site will be the different.
Yes, sir, yes. And it is used for mydriasis. It is not generally used for cycloplegia, but in recent studies, 1% tropicamide has been used as a cycloplegic for refraction,
For
retinoscopy and refraction, sir.
that is used tropicamide plus.
Phenylephrine,
Phenylephrine.
0.5%.
So that is used for the other use of this tropicamide plus phenylephrine.
Sir,
One is the retinoscopy,
yes,
or
sir.
the or other use.
Sir, in some forms of glaucoma, like malignant glaucoma.
Commonest use.
Commonest use, sir, for
What's the
dilatation.
best drug for malignant glaucoma? It's not
Only
tropicamide.
1 minute is left.
Atropine, sir.
only
That
1
tropine
minute
is
is
the
left.
mainstay.
Yes.
So what is the other use apart from?
Commonest use.
Cycloplegics are
No,
for
tropicamidals, phenylephrine, commonest use.
कहाँ
Anybody
करते
can
हैं?
do.
Daily
Every
use
day.
करते हैं. You
so
are using
dilating
every
for
day.
indirect
Oh.
ophthalmoscopy.
Every
नहीं,
morning,
नहीं,
theatre.
every day.
Daily.
In the
सुबह
operation
7
theatre.
बजे, 6 o'clock.
Pre-operative.
Yes, sir. Pre-operative for cataract
Very
surgery.
important.
Yes, sir.
Contraindications.
Contraindications,
yes.
it's contraindicated in primary angle closure glaucoma, and as it can close the angle or primary angle closure suspects, and
Anything linked with age?
age. In children, a smaller dose should be used.
Yeah, please.
Yes. So just one thing that there would be only 5 types of drugs which would be kept for your Viva: anti-glaucoma, ocular surface, anti-VEGF, and just leaking out the paper, ma'am. So anyway, so that you know the drop, so you must know everything about that drop. Just like I said for the instrument, you must know about the group it belongs to, the pharmacological action, the indication, contraindications, and for what duration it can be given. What is the advantage of using that? That it will cover all this. Yes.
So time's up for Nishi. Thank you,
Thank you
Nishi.
so much. Amazing, amazing. I think a big round of applause. She did very well. The next.
Yeah, we invite Dr. Aishwarya now onto the stage. A big round of applause for her too.
See, one thing while Aishwarya is coming here, the examiners know that you are very nervous, right? I'll relate a very funny story. So, you know, the exam goes on, the Viva goes on through the day. So there are breaks, and the examiner have tea and samosas served.
Come up.
So there was a time where tea and samosa was served, examiners were having tea and samosa, next candidate comes in, extremely nervous, and the examiner says, pick one.
कुछ
He
खाया कि
wanted to
नहीं?
pick instrument, but examiner, and they had a hearty laugh. And
कुछ खाया कि नहीं समोसा वोसा कुछ नहीं पानी पिया रात में नींद आई गुड नाउ यू पास
Identify the instrument. Show it to the camera first.
Show us the instrument, please.
And use the mic better.
What is it?
Mic. Use mic better.
What do you mean by McPherson and lens?
Forceps,
Lens holding?
lens holding forceps, McPherson's.
Don't have another one? Is it the best for lens holding the lens, or which part of the lens are you holding with this?
Optic
Optic?
and
You can do what you want. You can cut paper also with it. You can punch a hole. But what is the use it is meant for? It's a McPherson forceps is used for the optic or haptic. You might
Both-
flip.
both
It may go for to the, what is it called? Mid off, mid on, wherever. Okay? So with this if you hold.
and haptic.
An haptic to be implanted. In which IOL haptic to be implanted with
Yeah,
this
with
forceps?
Which haptic? There are two, no? When you insert,
Trailing.
trailing haptic. So there is another one to use with for the optic if you have to. So I mean, it depends on if you have a foldable lens, you don't need any of it, isn't it?
Which other type of the IOL holding forceps you know the name?
Shepherds for iris claw.
Yes. Or any famous Indian personality that are the sharp upper side of the edges. Tip are the upper side. Tip are of the upper side.
Sir,
You know the
for
upper-
lens, sir.
Yes, for lens holding. Another type of the IOL holding forceps that is named on an Indian ophthalmologist, very famous personality. He was not using it by person, but he own discoverer.
Sir, only the superior rectus Indian person.
No. IOL holding. That is Dalji's IOL holding forceps.
What is the power of
Iris
your
clip lenses.
glasses? What is the power
My
of
glasses.
Yeah.
+1.
+1? What would be your retinoscopy in undilated?
In undilated 1 meter distance with plane mirror.
Yeah. This question, you know, it is always asked. Those who come with the specs, myopic हैं तो अपना नंबर जो है इजी वाला याद रखना तुम लोग. झूठ बोल दो यार कि -3 लगा रहे हैं
At
सिलेंड्रिकल वाला नहीं बताना है, नहीं तो फिर वो पूछेंगे कंपाउंड मायोपिक है कि एस्टिग्मेटिज्म कितना है, विद द रूल है, अगेंस्ट द रूल है ना? So
+1 meter without cycloplegic, my correction will be +2 and +2 both sides, which distance correction will be +1 and +1 both.
And how much will you add for yourself? For near.
For near, I don't have.
Good, very nice.
And what symptom did you get?
Sir?
Would you get or should you get? What symptom if you were uncorrected? What symptom would you have got if you were
I had
uncorrected?
asthenopic symptoms. I had headache and
You
eye
already
pain.
had. That's why you know. Otherwise, you won't know. Okay.
You know the name of the retinoscope? Know the name of retinoscope? That is
This
plane and the concave mirror.
Plain mirror and concave.
No.
Okay.
Plane and both the concave mirror, name that retinoscope.
Which type of squint do you get in hypermetropia?
Isotropic.
Very good.
That is pissless with retinoscope.
Please.
Like this, yes, this specimen, yes. The topography. Yes, the topography in front of you. Yes.
Show.
So this is the pentacam image of around a 63-year-old male. Pentagram image of a 63-year-old male, Mr. Anand, left eye, and
What is basic principle of pentacam? And how many types of maps are there?
there is 3 types: the front and the corneal thickness map and the elevation map, float.
Principle of pentacam.
Uh,
What is difference between
Shim
pentacam
plug
and
and-
offscan?
It uses sheen flux is another thing.
There is one answer, you can say I don't know. Okay,
Confused.
always.
Yes, sir.
We,
Yes, yes.
So you can measure, you can see the posterior float with the pentacam map, whereas you cannot with the OBSCAN. The second thing, do you find the quality specifications correct in this? Before going on to again jumping on to your diagnosis, you want to see whether this map or this specimen is correct with reference to the quality specifications. How do you check for that? And this,
No,
No?
pentacam, I'm not very.
okay, you're not
And
versed
then,
with. Okay.
lastly, you must know the pentacam indices to diagnose keratoconus.
No, that is.
So a 24-year-old female, overweight female, comes to you with bilateral disc edema. What are the symptoms that you'd like to ask for? 28-year-old overweight female with bilateral disc edema.
I would like to ask for transient obscuration of vision as symptoms and headache, and I'm suspecting. Can I go for diagnosis? I'm suspecting idiopathic intracranial hypertension.
No, so,
or,
no.
sorry.
Idiopathic intracranial hypertension is idiopathic. So you are now thinking of raised ICP and papilledema. What next?
And so
Not a good idea to talk about idiopathic first. It's a diagnosis of exclusion, and you will miss serious tumors if you even think that way. You should not even be thinking that way. Okay, when there is disc edema, think of the worst in front, and also keep other things at the back of your mind. Okay.
So what investigation would you advise?
look to do MRI brain to rule out any space occupying lesion, and
supposing the papilledema is unilateral.
unilateral can be optic neuritis. I would like to ask for pain.
In which tumor you will find the unilateral edema? What is
This is
that is known as syndrome. Syndrome.
in case of frontal lobe tumors, we have optic atrophy in one eye and another eye optic disc edema, which
Yes.
shows a false unilateral edema.
And it's called?
First, Roster Kennedy and
That is the poster candidate. Good. Yes, Froster Fuchs spots.
Not sure. Not sure.
ए
Fuchs.
पीछे से नहीं बताना भाई, पीछे से नहीं बताना.
Fuchs. Uveitis.
Myopia.
Heterochromic iridocyclitis. Fuchs spots.
In the fundus, any Fuchs you find?
Anterior.
कॉर्निया में पीछे होता है.
कुछ डिश से चालू होता है.
Fuchs endothelial dystrophy. Talon Fuchs nodule is seen in sympathetic ophthalmia and in Okayanagi.
Yeah, what kind of BK?
First of
Pathological myopia.
Time over?
No, no, please go ahead.
Okay.
You can still fry her. I'm just joking.
So paracaine eye drops of 0.5% proparacaine.
क्या करता है?
Looks for topical anesthesia. Duration of action is around 12 minutes and can be used for
Onset of action, site of action, type of action, onset of action.
on sodium channels. It prevents the depolarization and gives local anesthesia for around 12 minutes. Onset, I'm not sure. And it can be used for topical surgeries where we use topical under topical cataract surgeries and nowadays also vitreoretinal surgeries.
Can you remove stitches also after putting these drops?
Yes.
Can you do Schiort's tonometry?
Yes. Schiort's applanation tonometer for stains.
Why you not use xylocaine topically? Because previous to intervention before the xylocaine was used, that is which percent? How much percent? Topical xylocaine was?
2%.
No.
It should not be used, so we have to dilute it.
No. Xylocaine used for topical purpose percentage. 4%. That was 4%. After that, the invented. Now, why xylocaine not used nowadays for the topical surgery? Topical phaco. Why? Side effects.
It may cause keratite,
Huh?
corneal edema on long time exposure.
There may be burning sensation with the xylocaine are too much. There may be the hyperemia. It is less and action of the paracaine come immediately. That is the main.
Corneal edema भी करता है.
Can I just interrupt, please? Judges, please use the mic because it's being streamed online.
Okay.
So you're not being heard. Thank you.
What's this instrument?
Bone punch used in dacrocystorhinostomy.
What are the contraindications of dacrocystorhinostomy?
Infection, local site
Infection में तो वैसे ही नहीं
in
करते.
dacrocystorhinostomy.
तो acute हो गई. Chronic में आप कर रही हैं ना? तो what are the contraindications of doing DCR?
Bleeding this one.
Any age group?
नहीं मालूम. Okay, no problem. ठीक.
बच्चों में करोगे DCR? बच्चों में, children
Children.
करोगे?
Atrophic
Cannot
rhinitis
listen.
is the absolute contraindication for DCR.
Whenever you answer the instrument,
Atrophic rhinitis.
Yes.
whenever you answer the instrument, say the full name.
Age.
What type of bone punch is it?
Kelly's bone punch.
It's not a Kelly's bone punch. And sir asked you about in which indications. What is the size in that surgery which you will use the bone? How much? What's the end point of the bone punch?
Dimensions of your
How much? How longer will you keep using the bone punch in that surgery?
Did we see the nasal?
Have you done it sometimes?
I've observed it.
You have
twice.
observed. It's very easy.
Between the lacrimal sac and the nasal mucosa.
Which part of the nasal mucosa? Mucosa is one long thing.
Big area.
Which meatus?
Inferior.
This is a basic
Middle
thing.
meatus.
What is the normal passages in which meatus?
Normally it opens in inferior meatus. So we do in middle meatus.
What are the types of the bone punch you know? Can anybody tell? There are two types of the bone punch. There are two different names. Kelly's and another is Thales bone punch. Citales, So that's why there is a hole in.
Glaucoma, ji. I know.
That is the Snellen's bone punch, and another one is the.
Mike, please.
So there is, and one there is will be hole. The bone will pass, and another one there hole will cut and remain in between these two.
Okay, very nice. Thank you so much. You have done very well. Good.
Thank you.
The next candidate, please.
Big round of applause for Dr. Aishwarya. And whilst Dr. Anurag is coming up to the stage, can I just invite another esteemed member of ophthalmologist, Dr. Rajendra Singh Chauhan, who's professor ophthalmology at RIO in Rohtak in Haryana. Welcome.
Hello, sit down.
क्या खाया है तुमने यार? सुबह कुछ खाया खाना वाना? पढ़ा है
English,
खूब?
please.
रात में
Please
नींद आई है?
communicate in English, sir.
Good boy.
Relax.
चलो question.
Identify and tell the uses.
This side, onto the camera. Thanks. 1 minute. It's not visible.
खोल लो ना ये रहा खुला हुआ अच्छा सेपरेट अलग
Please hold it up. What is it?
आराम से
Be careful.
He may injured himself.
Yes.
Did you measure it 2.8 written because it may be 2.4 also 2.2 also.
What is it dependent upon? The size of this is dependent upon what other parameter? Because it has to be very precise. Which surgery are we talking about? Okay, so what is the other one which based on which this is made? Which is the other diameter you need to know? No, which other instrument tip makes a difference for this? Why are we having 2.8 and not 2. What does it depend upon? You have 2.4. You used to be 3.2 earlier. What is the funda?
It's more working, I think.
So it depends upon the tip of the phaco machine.
Ma'am, because phaco machine has 2.8 mm tip on it, so it provides 2.8 millimeter incision in clear cornea. So it will facilitate the
so it
instrument.
depends on the phaco tip.
Yes,
The size is
2.8.
entirely dependent on that.
Yes.
What if you make a loose fit, tight fit? What happens?
Ma'am, if there's a loose, we make the bigger incision by 2.8 or it's bigger than the size of.
What happens?
So it causes leakage of the fluid during the phacoemulsification.
So what if it leaks? Anyway, it leaks.
No, ma'am. So
it leaks quite often.
It's caused the imbalance of the AC. So it lead to
Not
PCR.
imbalance. So it was shallowing.
Yes, shallowing of the AC. Yes,
ballooning. So
yes,
it cannot leak
Sir,
indefinitely.
sorry, sir.
And what else it will do?
Sir, so PCR rent.
No. Don't go to that stage. It will keep coming off and then you will not be able to see.
Yes.
Visibility will be a problem.
Yes.
Okay?
Yes.
And if it is tight, what will happen?
Yes, sir.
How many size of the keratome you know?
Sir, I know 1.8 mm. Generally, we are using in our setup 2.8.
2.8.
Other is 5.5 mm.
5.5 is history now. So nobody is using.
5 point is.
So 2.8 and
2.8.
other is 3.2
3.2
is
and below that
Below
2.8.
2.2 is most commonly used.
Yes.
Because lenses are available in this size.
इससे SICS कर सकते हैं?
Yes, sir. In SICS, in the process of SICS, we
Yeah.
use 2.8 incision for after making tunnel. We enter by the 2.8 and 2.8 instrument, and then we flip the borders.
What is a good configuration of SICS?
Self-sealing valves. Self-sealing valves.
Yeah, how do you do?
Which one is the best incision for SICS?
A frown shape incision.
तो self-sealing कैसे होता है इसमें?
Sir, because of valve action, because we make a frown incision, so when we create a three planar incision in the clear corneal space, So it provide a self-sealing wall which
How much you go in the cornea?
sir 1.5 mm above the cornea, inner part of the cornea, sir.
Okay.
What are the types of incision in SICS?
Ma'am,
And which one will you do when?
Ma'am, first is straight incision, second is smiling, invert smiling incision, frown incision. Yes, sir. And third is W-shape incision. Nowadays, a V-shape incision also, ma'am. In some.
So which one will you do when? You have named 3 of them. There are more than 3, but okay. When will you do a straight, when a frown, and when a chevron?
Ma'am, when we neutralize, when we have correct the astigmatism, if against the rule, when we are superior, we are sitting in the superior position generally in the SICS. If there is a with the
When
rule.
will you do a temporal SICS then?
Sometimes.
No, sometimes what are the indications for a
Depending on
temporal
the
SICS?
steepness.
Yes, ma'am. Depend upon the steepness. If we have no toric lenses, the astigmatism is very high, 1.5 or 2 mm. So that we help it out with the SICS incision.
Out of the 3, chevron, frown, and straight, which is the least causing the least astigmatism?
Frown.
Chevron. And you will do a temporal SICS very often in glaucoma surgery when you have a hard cataract. You don't want to touch the superior area.
What is this? मैम का है
Mike.
In which there's a picture of OCT RNFL, in which we see the OCT picture. Sorry, sir. Fundus picture, sorry. My bad, sir. Fundus picture of right eye and the left eye, which is showing. This is the red free image in the bottom and the above picture in which see the cup disc ratio is.
नहीं कब डिस्क पे कहाँ गए कौन सी आई है ये?
Sir, first right side is the right eye and. Ma'am, the phobia is in the.
Mike, please.
You read
Ma'am,
from the top.
because of the arcuate and the phobia structure.
What is the line which is you have to check? Where should the phobia be?
Fovea is in the
Right or left?
lower or above the center of the disc line.
Sir, below the center of the disc.
She's not taking
Now we are showing this picture showing a fundus photo of the both eye, right and the left eye.
एक आई की बताओ
In which we see a blood vessel broad. In which media is clear. This CDR ratio is 0.4.
Before that, see,
How
before
you will
going
start
to the
the-
disc, you must describe the disc in total.
How will you start the
The
examination
margins
of the
of the
disc?
disc, structures around the disc.
Yes, sir.
Then visually.
You see, this
then
is
mention
for
about the
you all
neuroretinal
sitting there when you are examining a fundus. You must always write media are clear. Disc size is this much.
Size, margin,
Margin
color,
is this much.
cup.
Shape is this much. Cup is this. Neuroretinal rim is this.
Surface of the
whether
disc,
there is any
vessels
hemorrhage or not.
arising.
Whether new escalization. So you have to describe everything. It's directly don't because it's written there. It's glaucomatous. So don't jump onto the glaucoma. Okay.
Yes.
So you start now.
Sir, this is a fundus photo of the right eye showing media is clear. Disc
Media are clear.
Media are clear. Sorry, media are clear. Disc size, disc margin is sharp. CDR ratio is
Well defined, ill defined.
well defined margins.
What are the causes of ill defined disc margins?
So papilledema.
Start with the other than papilledema, optic neuritis.
Yes, sir.
Other than these two.
AION maybe, sir, there's a optic.
Think of something common conditions without any pathology.
Pseudo
सबसे common
Pseudo
pseudo आगे
Sir, hyperopia is
हाँ सूडो आगे
Hi-
तो क्या कहते हैं सूडो
pseudopepileptic. Yes, sir. It's hyperopia. Most commonly we see in the clinic, sir.
What is diameter of optic disc?
So 1.5 mm. Generally, in the general.
नहीं vertical or horizontal both. Tell you are PG student, so you tell accordingly.
Okay, sir. One.
Which one is? कैसी होती है डिस्क कैसी होती है normally?
Oval shape. This is a
Kौन
oval.
सी oval?
Vertically or horizontally?
Vertically or horizontally?
Vertically, sir. Vertically is large and the horizontal is.
तो फिर बोलो.
Tell vertical dimensions and horizontal.
Horizontal.
So vertical dimension is 1.7 mm and the horizontal diameter is 1.5 mm.
Never ever give one figure. Always
Okay,
give a
it's
range.
a
Always. Never
range,
give
it's
one
a range.
figure.
Okay, ma'am. Yes,
Okay.
it's a range.
So how will you describe, this is obviously, if it's a red-free picture beneath,
Yes, ma'am.
and you have a disc photograph up, what is the clinician wanting to know? What is the disease
As
pathology?
per red-free printer, just we see any defect, any RNFL defect, we see
So what disease are we looking at?
glaucoma.
Okay, so in the glaucoma disease, what are the other disc parameters which you have missed?
First is, ma'am,
Size
cup
is
disc,
media carity ho gaya, size then
cup disc ratio is
straight away.
then
Size then
shape,
we just talked about shape then
and the color
of the rim or the color of the cup.
of the rim.
So look at the rim.
Yes, ma'am.
Rim,
And then the sign, the blood margins. There is a blood vessel bayoneting as a
first you
bayoneting
look
sign
at
or
the
not.
cup signs, your rim signs and vascular signs,
Yes,
and
ma'am.
then peripapillary sign.
Yes, ma'am.
So let's divide it on that. We talked about the disc abhi tak,
Yes, ma'am.
cup signs.
Cup side is in a right eye is probably it's 0.6.
No, cup signs. So what is Armley ratio? What is DDLS ratio scale? What is Armley ratio and what is DDLS? And why are people coming? All the OCT machines have DDLS inbuilt into them. Why?
Because of the variation, of the Indian population, there is a variation of the cup, the optic nerve head ratio in the
So
general
none of the
population.
machines are made by Indian companies. They're all made by American companies. It's not for India at all, actually.
Yes, ma'am.
So let's talk about, so there's a racial variation. Why is Armley ratio not so frequently talked about? DDLS is more frequently talked about. Why?
Because of, ma'am, the condensation of the nerve fiber is more in the superior and the inferior quadrant. So
No.
that time,
Because Armley ratio just focuses on the vertical disc diameter, whereas DDLS focuses on the
Horizontal.
neuroretinal. No, it doesn't focus on the diameter of the cup at all. It talks about the neuroretinal rim dimensions. And it talks about the disc sizing, which has a racial predisposition. But there are obviously some fallacies. What are the other signs in the peripapillary area? I haven't seen the picture, but I'm just asking you what you look for.
ma'am, the base defect,
Yeah, alpha.
alpha or beta zone.
And what is
Beta
gamma?
zone.
How do you see gamma on the disc picture? How do you see the gamma in the disc picture? Anybody knows about the gamma sign? It's not seen in disc picture. It's an OCT finding on the disc. Okay, you look up what is gamma. All right, then nerve fiber atrophy. How will you see in the red free?
Ma'am,
How will it look like?
darker than the surrounding area. The nerve fiber defect shows as a darker area.
Would it be arcuate? Would it be wedge-like? Would it be diffuse? If it's high myopia, would you have a nerve fiber atrophy? Post-LASIK surgery, what would be the picture? Wedge defect would be in which condition, and slit-like defects would be in which condition? And what is isn't rule? I'm just throwing words at you to understand that is how you look at the disc in entirety. Size, shape, disc signs, cup signs, vascular signs, then the peripapillary area signs. Okay?
Thank you very much. His time is up. Dr. Anurag, well done. Round of applause, please. The next one on stage is Dr. Srishti. Welcome. Any comments from the judges, examiners, sorry. So far?
Good going. Judges have asked good questions.
Thank
and
you.
That reminds me, for me at least, I don't talk about the other judges. The question which I ask, I don't know the answer of it.
Please use mics. Can I just remind you, please use mics. Thank you.
It was not for public consumption. So mics were not used.
What is this?
Mic.
All these.
What is that? Name the instrument, please. Same one?
Ma'am, it's a needle holder.
Oh, okay.
What's this? These are simple. Needle holder.
So these are muscle to hold the muscle head.
Which is this? Is it a muscle hook? What do you see? Just put it up.
Cut end of the muscle.
What is the name of that instrument? Why cut end of the muscle? Is it a tooth forceps? What is it? There's no such thing as tooth.
Hold the muscle.
No, what is the name of? What is the name of this?
Glove fixation.
Name of? What kind of tip? Yes. हाँ. कितने tooth होते हैं? कितने tooth होते हैं? हाँ.
And what are the applications?
Chalo, pick up any instrument of your choice.
Never pick up.
That was
your
fixation
choice.
for sir.
I gave you the tip. Never ever fix. That's you decide. Because if you have chosen and you are not able to answer, then you are responsible.
It's a Simcoe scanner.
हाँ?
Simcoe scanner.
Simcoe नाम full name Simcoe.
There are two Simcoes, reverse and so what
regular
is
and
with these two Simcoes?
Full name of this Simcoe. वो देख रहे पीछे बोल रहे हैं irrigation and not
aspiration scanner.
नहीं reverse होता है direct होता है तो ये कौन सा है?
Direct.
how you can say कैसे पता लगे?
So this tip is used for aspiration and the other one is for irrigation.
What will be the difference between these two hole or port? Aspiration port and the other for the irrigation.
Yes.
There has to be different configuration of these two. And the syringe positions, that will change.
Okay, where it is used?
So for small incision cataract surgery.
One is the for aspiration of the.
You can use it for phaco also. Yeah.
No, one is
It's
for
the most
lens
important complication.
aspiration or
So PC range, ma'am, it can
no,
be
what are the other uses? One is the lens matter to be aspirated, remaining cortex or क्या करते हैं सर? और क्या? Hyphema और
hypopion.
Hypopion जब कभी बहुत ज़्यादा थिक आपको थोड़ा सा uveitis तो you can aspirate.
करते समय what care you take while aspirating the cortical matter?
The height of the bottle height.
नहीं,
And
with Simcoe what care you take? You are operating there, height is fine, everything is fine, fluid is coming nicely. What care would you take while doing cortical aspiration so that complications don't occur?
Direction of the
Please hold the mic close to your thing.
so the
Anybody
cortex
from the audience? Yes.
beneath
Anterior
the-
capsule?
हाँ बोलो.
Posterior capsule. What care you take? Huh? There are two reflexes on the posterior capsule while you have a good red reflex. What are those? A ring reflex and a. Oh, that is very important. You see. Sign.
star sign is there, ma'am. In case we catch the capsule inadvertently during aspiration, then star sign is seen on posterior capsule. Radial sign.
What will you do then?
Then we use reflux, ma'am, and we
Reflex you use or you can. Isme, that is not phaco.
Without phaco,
It's not phaco, no?
we gently release, ma'am. We
No,
don't
you just
pull it.
stand still, the infusion will take care. Don't withdraw is the more important thing. Don't withdraw. And don't withdraw your, stay safe. Stay there and breathe deep.
कुछ है नहीं है, बहुत ज़्यादा कुछ नहीं है, बहुत obvious सा नहीं है ना, ये वाला करते हैं।
See, again, when you took the Simcoe cannula, your description should have been that it is an irrigation aspiration cannula by the name of Simcoe's cannula. We can use this for aspiration of cortical matter or blood from the anterior chamber. It can be used in cataract surgery. It can be used in any trauma procedures, any repairs where you want to aspirate, cortical matter or blood cells from the anterior segment. It can inadvertently injure the posterior capsule, so we should be very careful while manipulating this with in the anterior chamber. You should not be going close to the posterior capsule. You should not be also holding it in iris inadvertently with this cannula. Okay, otherwise it is a very safe cannula. There are two types, that is the direct and the indirect. So that could have finished your, so you forced us to ask you everything now. You don't know the answers to everything. So
and remember, as for
the
saline,
description should be complete.
What is
okay?
this?
So this is a right eye scan.
One second, please. Hold it up once again, please.
Hold it there. There.
Yeah.
The camera is there.
Yeah.
Okay, fine. Describe.
So this is a right eye scan of a male. This is the anterior segment optical coherence tomography photograph of a right eye of an individual, and it shows there's a anterior segment photograph also there in the inferior half of the scan, and on anterior segment OCT photograph shows subepithelial bullae with corneal edema, that is increased thickness of the cornea, and on the anterior segment photograph it is air bubble is seen in the photograph. And
Why do you say it is air bubble?
the reflex is like that.
Can't be any other inert gas.
It can be gas also.
What else could it be other than air bubble? And why would you want to put an air bubble? You don't assume it, no? You have to just.
In case of Descemet membrane detachment, to reattach the membrane. There is significant Descemet membrane detachment, which was, I think, tried to, or to reattach with the help of a tamponadma. Intra.
Again, the same thing that you want to identify that this is an anterior segment OCT. You can see that this is a transverse section of the cornea which is being seen. So first image is of the cornea. The second is the diffuse examination of the anterior segment, which shows you the pupil, the cornea, and the anterior chamber. So these are the two descriptions which you should have first. Now go to the pathology after describing this. In the pathology, you can see different things in the superior picture, that is the section of the cornea and the overview of the anterior segment. So describe them both the things separately. Now do you want to, revisit it and describe it again?
And see for the thickness also.
She told that it's increased thickness.
You may have DSEC, DMAC post cases.
Yes, sir.
You may have.
So the superior half of the photograph shows the anterior segment transverse scan of the cornea, the anterior segment OCT photograph. And in this photograph, subepithelial bullae can be seen with increased corneal thickness and Descemet membrane detachment. And in the lower half, the diffuse illumination photograph of the cornea showing the anterior segment is seen.
Here you are not measuring the cornea. You can just say that I feel that the cornea may be thickened in this case, though the measurement is not there, the quantification is not there. You can confirm it only when you get that quantified view of that section. That is correct that you are seeing the
What are the causes of this?
And
corneal edema with bullae.
So in case of post intraocular surgery, it can happen, sir. And
What is that called?
Descemet membrane detachment.
Detachment तो है और कुछ
इसमें है
Pseudophakic bullous keratopathy, chronic cases. If three corneal
PBK, it could be ABK, it could be after glaucoma surgery. So when you have a long-standing corneal edema or the corneal edema post-operatively, immediately you get a OCT scan done. It cannot be seen by slit lamp. Then you look at the OCT whether the Descemet detachment is there or not. Corneal edema can be present otherwise also. Okay, and when you see epithelial bullae there, that means the corneal edema is marked, and that needs to be corrected. And in this, perhaps this is the air bubble only.
Yeah.
This is the air bubble only. You can see all of you. कैमरास दिखाओ नीचे वाले डायग्राम में देखिए एयर बबल है तो ये डालिए टू अटैच दी desmats. What else can be used?
Why can't you use HPMC to fix a?
Ma'am, SF6 can be used if the detachment size is longer.
Why not
more
just
quadrants are
plain
involved.
heel-on or a HPMC? Why not HPMC?
It will increase the intraocular pressure.
No, any of these will increase.
It depends on the size of detachment.
Not really.
You can put prolonged period of attachment so that edema can be.
No, the liquids you use will go between the layer. So it has to go. It will go. It will form a layer between the desmats, detached desma, and the rest of the cornea. So not the best option.
How do you inject the air so that it does not go into the corneal stroma?
We make a paracentesis, sir, and then we.
No, how you inject the air?
From which side would you inject the air?
Where the flap is visible, just.
No, that is not.
Then you
From the flap. That is again causes.
Problem of
on the opposite side.
Opposite side of the wound. That is very important. If you go from the other side and inject air, it gives you very good result. The next day you will find cornea becomes transparent. SF6 is not injected. Many times we inject, but it should not be injected because it increases in volume and can cause secondary glaucoma.
What is the radius of the curvature of the cornea anterior and the posterior surface? That you should know. कौन सी curvature ज़्यादा होती है? So radius of curvature inversely proportional. Which one is the steeper? Posterior. So radius of curvature of anterior and the posterior?
Same posterior.
No, it's 7.6 and 6.7. Anterior and the dioptry power of the cornea, anterior and posterior surface?
46 and
No,
43.
no.
I think I need to come to her rescue now.
6 is per
surface
posterior.
is how much?
6.
Her time is up.
6 plus 6 or minus 6? Last.
So that is the true physiological toric.
You can thank me, Shrishti.
Yes, just one comment that always know the quantified, readings of all the anatomical structure, the radius of that.
Anyone
That is
else?
very unforgiving if you are not telling it in the Viva. The anterior posterior curvature of the cornea, the lens, the nodal point, the basic anatomy, the quantified values you must know, okay? Because somewhere in the Viva you'll be caught on this. So make that, brush up that, quantified readings always.
Thank you very much.
Good, very nice.
Please do note these points. They are very important.
Do you know the Nobel Prize, the first Nobel Prize of ophthalmology was given just for this answer, the schematic eye? Anybody knows what the first Nobel Prize for schematic eye was given? Yes? Alva Gulstrand was given the Nobel Prize for schematic eye for giving the dimensions and how the optics works. He was given the Nobel Prize for that. So it's a very important answer.
Yeah.
That may also come as a question. Right. We now invite our last candidate here, Agrima Bhatia, Dr. Agrima Bhatia.
कोई
Round of applause, please.
लड़का एक ही था क्या?
Where are you from? Which hospital? Command Hospital.
Command
Okay.
Hospital. Not from Bangalore. Okay. Rima, may I ask you a simple question? First, pick up this blue top bottle. Yes. Just tell me what is this?
Here, this way. Camera is here.
So this is a topical combination of tropicamide with phenylephrine.
Yes. Now put it down. Tell me the percentage.
So tropicamide is 0.8% and phenylephrine can be in doses of 5%, 10%.
No, about this only.
This one is...
No, don't read.
Acha.
What is the
So
point?
then it is... So tropicamide is 0.8% and this is 10%.
You are using it very frequently.
Next you will ask expiry date.
10% is phenylephrine and tropica is 0.8%.
10% is phenylephrine and tropicamide?
0.8%.
Up pado. Now pick up and tell the exact and loud and clear.
Tropicamide 0.8, sir, and in this one phenylephrine is 5%.
So it is not 10, it is 5%. Can you put this in ROP screening?
So we usually dilute this and then we use it
No,
for
why
ROP
usually?
screening.
Why not always?
Sir, because of the dose of the...
No, that is what I am asking. You usually or you will
You
always
must,
dilute it?
you must, it's mandatory.
We dilute it always, sir. It's
How will you
mandatory.
prevent intraoperative meiosis? Despite putting this, you will have trouble in
Ma'am,
the
we can
OT.
use fluorbibuprofen
When?
Pre-operatively, half an hour before the surgery to prevent intraoperative meiosis.
Anything else?
Other than fluviprofen. Fluviprofen, which group of drug?
So it's an NSAID, a non-steroidal anti-inflammatory drug.
Other non-steroidal
Ketorolac.
आजकल कौन सी चल रही है? फ्लूविप्रोफेन यूज नहीं करता है
आजकल तो ये it's not available.
Nepafenac is used because it
Can you tell me one thing that this NSAID group of drug you will not use in which group of ocular morbidities or which conditions you would not use them? The NSAIDs, yes?
Ma'am, in cases of chemical injuries, immediately post-operative, immediate after a chemical injury, because they may act on the keratocytes. Actually, the role is not known. And apart from that,
yes,
ocular surface disorders,
yes,
we will not use the NSAIDs. So, this is a punctal dilator. In the name of nettleship. So this is a nettleship punctal dilator, which is used for dilating the puncta before we do any lacrimal syringe.
From which puncta you are doing the syringe?
So inferior puncta and superior, we first start with the superior.
Why with the inferior puncta you are doing commonly?
Because the maximum drainage of tears takes place from inferior puncta, around 70%.
Why you are doing with the lower puncta commonly, not from but upper? Because if you injure the lower puncta, 70% fluid
of
glucose
this
will
is
be there. So why you are not doing upper puncta? Where the lower puncta situated, where the upper puncta situated?
Approximately 1.2 mm from the...
1.2 mm.
It is a little towards the interior, that the upper puncta.
Anterior. One is the anterior or
Anterior.
main thing. That is
the
Okay, where is the block in congenital dacryocystitis and in adult acquired dacryocystitis? Where is the block?
It is at the level of valve of Hasna in cases of...
Where is that?
Inferior meatus, close to the inferior meatus. And in adults, it is at the level of the junction of the sac and the canaliculus. Sac and duct, NLD.
Sac duct junction.
Sac duct junction.
what are the other valves you know?
Valve of frozen molasa.
Or
You must have been using IV mannitol in many patients.
Yes, sir.
What is the percentage of mannitol it is?
Sir, it is 20%.
20%. Should be given fast or slow?
Sir, it should be given over a period of 15 minutes.
Tell me
Fast.
Fast. And what is the dose?
So 1 to 2 gram per kg body weight, sir.
Good.
Ma'am, hypertensive urgency or emergency?
Contraindications, I'll just repeat the question. Contraindications for giving mannitol.
Ma'am, hypertensive urgency or emergency? Like
one specify contraindication for the mannitol. Specify. Name of disease. Which organ is affected? For that disease we should not give.
Pulmonary edema.
Pulmonary edema, you don't want to give. Pulmonary edema patient आपके पास पहुँचेगा ही कैसे बेटा?
Renal toxicity it causes. So in chronic kidney disease patients, we will
It is a CDK patient. What else? Anything in the brain you want to rule out for?
Increased intracranial tension.
That is the treatment. One of the indications is that Dimox and that. Okay, we were going back to the syringing, where the question asked was, will you do it from the superior punctum or the inferior? So, and I would ask a further question, when you do a probing and syringing, You will do it from the superior punctum or the inferior punctum, and why?
Ma'am, in congenital NLDOs, we will do it from inferior, as it may be both diagnostic as well as therapeutic.
You will do it from superior.
Superior.
Why? He gave you the answer. In
The
the
drainage
part.
is maximum from the inferior.
चलिए
एंगल की बात होती है ना, एंगल किधर जाता है बेटा?
What are the other?
इसमें जो है देखिए, आप ऐसे जाते हो, फिर ऐसे जाते हो, फिर ऐसे जाते हो, और ऊपर वाले से ऐसे गए, एंगल उतना नहीं, इसमें एक्यूट हो जाता है, उसमें इजीली.
What are the other hyperosmotic you know, other than the mannitol?
Sir, acetazolamide.
Other hyperosmotic. Acetazolamide किस ग्रुप की है?
Something sweet.
What? बताओ कौन से ग्रुप की acetazolamide?
That is carbonic.
ये तो वो बता रहे हैं. They are telling you don't other hyperosmotic agents which given orally. How?
Glycerol.
Or
Glycerol 5%.
No.
50%.
or mannitol और ग्लिसरॉल और एक और होती है तो अपन कराते हैं सीरम क्रिएटिनिन एंड सीरम यूरिया.
Sir, this is a 4-quad map taken by the machine Pentacam, which is a Berlin Ambrosio enhanced ectasia display of the left eye. The quality score of this map is okay, so we can proceed with assessment of this. In this, the age of the patient is, the date of birth of the patient is 27th April 1956. So, and the quality, Kmax is 48.9 diopters and K2 is 46.7 diopters, which shows a difference between the two. Then the Pachy thin is 396 and the apex, Pachy thin local is not mentioned. Apex is shown as 396. Assessing the maps, first is the
what is residual corneal thickness? Bed thickness.
Ma'am, 250
No, what is the meaning of that?
Ma'am, after
that can be anything, yeah.
After any laser corrective surgeries, whatever is the residual thickness which we should leave minimum for any post-refractive ectasia to occur, that is...
Not to occur, sorry.
Not to occur is a residual bed thickness.
Yes, it is not one fixed number, it's variable, but generally it is there, what you said.
So it was a good description. You must describe all the specimens like this only whenever you are getting, to answer this in Viva. Second, just one question in this, how do you get to know the angle alpha in the pentacam? Can you know the angle alpha? Does this machine tell you about? Yes. Does it? Okay.
CT based, I think. I'm not sure of this.
You're not sure. Anybody? Can the pentacam tell you the angle alpha?
One instrument नहीं one.
दे दिया ना.
Yeah, she got that. She got the other one also, I think. Medication. Yeah. What is posterior keratoconus?
Ma'am, the keratoconus, it's a non-inflammatory progressive ectatic disorder which shows progressive thinning, and it is first to start on the posterior corneal surface. So when it...
How do you diagnose that? What modality of imaging you need?
Ma'am, now latest modalities like anterior can... Yes, yes.
What is lenticonus?
So the shape of the lens is...
Which surface?
The anterior surface of the lens is conical.
Normally, which surface is conical?
So the posterior surface.
Can you name four forceps used in ophthalmology? Forceps.
Forceps used in so we have the McPherson's forceps. We have the Y-shaped lens holding forceps. The Stur superior rectus holding forceps.
What is the difference between Hodgkin's and...
The Stur superior rectus holding forceps. So we hold it like.
In which surgery it is used?
Sir, it is used in the small incision cataract surgery to hold the superior rectus.
One only?
Sir, it can be used in other surgeries also where we want to give a bridal suture.
Which is that? Name them.
One is the SICS.
Sir, even in trabeculectomies, to give better exposure of the superior conjunctiva, we can use this.
What is the better alternative these days?
We can give a traction suture. Cornea, we can give a traction suture, sir. We can avoid using less trauma. Sir, it can be traumatic and it can cause incomplete insertion.
Thank you, Srishti. Thank you.
No, she's
Sir,
not
if
Shrishti.
there is
She's Agrima.
Time over. Very nice.
Thank you very
Very
much.
nice.
Big round of applause. It's not easy to come up and answer under the scrutiny of so many people. It's always easier to sit on that side and answer the questions that are being asked
You
on
all
this
have
side.
done very well. Nobody can answer all the questions. Even we cannot answer. If I am sitting there, I would be really flabbergasted because they are asking very simple question. At times, it's very difficult for us. So it's very well done. You have all done. और पीछे से audience भी बहुत अच्छा कर रही थी. You see, when we take exams, पीछे से लोग इशारा करते रहते हैं, ये बता दो, ये बता दो, ये बता दो. जूनियर कंसल्टेंट जो है ना इशारा करते हैं उसमें गलत हो जाता है. वो उनको खुद भी नहीं आता, वो गलत आंसर देते हैं. इसलिए खुद पढ़ो और खुद सीखो और इंस्ट्रूमेंट्स खूब देखने हैं आपको. सारे इंस्ट्रूमेंट, सारे ये जितने भी आपके इन्वेस्टिगेशंस है, ये और एक हैस स्क्रीनिंग नहीं रखी है यहाँ पे. दैट ऑल्सो यू टेक द चार्ट एंड रीड इट एंड टॉक amongst yourselves. Third year resident, second year वालों से discuss करो and teach them. If you teach them, you learn more. Okay? So this is what you have to do. You are all very nice residents. Some of them have gone. They must have missed a lot. So thank you so much.
Thank you so much. We have to thank all our examiners here who've been very, very kind with their time, their questions, their efforts. I declare the results now. I'll start with the third position. It's Dr. Nishi. Where is she? Stand up, please. Can you just, we don't know where you are from.
Good morning, good afternoon, everyone. I'm from Safdarjung Hospital.
Okay, right. Okay, she's a localite. Fine. The second place, second position to Dr. Aishwarya. Did you tell us where you're from? No. Please come and tell us.
From Southern Railway Hospital, Chennai.
Okay. Please come onto the stage, both of you. And Dr. Agrima Bhatia. First position. Very well answered, I have to say. Well done to all of you.
और बाकी दो लोग हमसे अवार्ड ले लेंगे बाद में आके. ठीक है? All five deserve. Yes.
For some reason, I don't agree with this giving of awards here. That gives you a false sense of complacency. Never be complacent. Exam is an exam, and not only exam, the whole process is of learning. So never become complacent. Never think you know all, never think you've done it. You never have done it. You will keep doing it. So just never become complacent. That's a very simple thing.
नहीं,
I
अवार्ड
can say.
मिलना चाहिए भाई, हम तो एग्री करते हैं इससे. अवार्ड मिलना चाहिए और हम लोगों को भी मिलना चाहिए. नहीं, हम लोगों को भी मिलना चाहिए. इतनी देर दूर से आए पढ़ाने.
As with everything in life, there is always two sides to a coin. Yeah.
पिक्चर ले लो, बाकी दो को भी बुला लो यार.
One picture with all the three winners, and then everybody can join.
All
and
the
participate.
candidates, please come.
Come.
All of you, you appeared for the test. कोई फेल नहीं हुआ यार. It's just.
So, Agrima directly qualifies for the Star of iFocus finals. Okay, so.
हम आगे बैठ जाते हैं.
So while the stage is being reset, just give us 2 minutes and we'll get back. So I hope you guys are seeing the interesting posts that are coming up on Insta. You are the center of